Welcome everyone. So the next session is on complex cases and practical solutions. To start with the first case, I would invite Dr. Karthik Vasudevan, and he is going to take us through the case of my most challenging PCI. So Dr. Karthik Vasudevan is Chief of Interventional Cardiology, Heart Failure and Transplant Program at Manipal Hospital, Yeshwanthpur, trained in heart transplant and LVAD. Principal investigator for Shockwave Registry, principal investigator for Tuxedo, and he's been an investigator in various clinical trials. So over to you, sir.
Hello. Thank you, Dr. Said, Dr. Singituvel, and Dr. Lupin for giving me this opportunity. So I'm going to present one challenging case. So this is a 80-year-old gentleman who presented with class 3 exertional angina 3 months before with worsening to class 3 since 1 week. So he had undergone coronary artery bypass surgery 16 years back. He had received 3 grafts, Lima to LAD, SVG to OM and RPDA. He was hypertensive, non-diabetic. Echo showed regional wall motion, predominantly in the infralateral wall, and LVEF of 35%, and moderate mitral regurgitation. So coronary angiogram was done elsewhere, and it showed Lima was patent, but LAD beyond the anastomosis was occluded 100%. The SVG graft to OM and PD was also occluded. He had a native calcified tight distal left main bifurcation disease. So that's the angiogram. So this was done in some other hospital. So this, you can see a tight left main distal calcified lesion there. And the grafts, both the grafts, SVG to OM and PD were occluded. And the Lima was patent, I can see here, and post-anastomosis there was no, completely occluded. And there was it was collateralizing the PD. The posterior descending artery was filled by this, one of the small twigs which was coming from the Lima. So with this anatomy, he was offered medical management elsewhere. For 3 months he was doing well, but then he became extremely symptomatic. He couldn't even go to the toilet. He had so much of angina. So then he was referred to a center. So this basically is a high-risk case. If you look at the CHIP score, it comes to 10. Age more than 80 and prior MI, lesion length more than 60. And because of the heavy calcium, we planned to use a rotational atherectomy and severe LV dysfunction. So we had to use an LVAD to do this left main bifurcation stenting. And so if you look at the CHIP scoring, the cumulative MACE is around 14.6. Anything above 5 is a CHIP case. So we planned to do this, and we explained in detail to the relatives about the plan. But they took some time to decide. Meanwhile, after 1 week, he presented with ACS, arrest angina, and he developed NSTEMI. So when they came, so immediately we had planned already, so we went ahead. We inserted the Impella 2.5 before the procedure. Then when we did the angio, you can see the circumflex was occluded. Earlier it was flowing, now the circumflex was totally occluded. So immediately we wired the LAD and opened it with a balloon, 2 millimeter balloon, and the circumflex started flowing. You can see the distal tight left main heavily calcified lesion. So the plan was to and then after that, we wired the circumflex. The usual BMW didn't cross, so I had to take a Fielder XT wire. That's quite at a right angle and quite tough. And we pre-drilled the circumflex also, so good flow was established. Then we thought we'll image the patient with an IVUS. So this is the IVUS run. You can see this from the LAD. Distal, there is about 360-degree calcium. Mid also, this heavily calcified. And if you look at the left main, there's a big calcific nodule sitting at the left main junction, the polygon of confluence, protruding into the LAD and also into the circumflex. So after we saw this, we decided to do the rotablation. So this is the run from the circumflex. The circumflex also was calcified, not to that extent as the LAD. And if you look at the left main from the circumflex, you can see the nodule also protruding slightly into the circumflex at 11 o'clock, 12 o'clock position. So we took 1.5 bar and did about 5-6 passes at a speed of 1.8 lakhs. And after that, we did the IVS run again. So you can see the nice calcium cuts in the mid LAD. And here, especially in the left main, you can see the calcific nodule partially it was shaved off from one side. So the other side was still remaining. So we thought we'll do the burring from the other side also. So we put the wire in the circumflex and we did the rotational atherectomy from the left main to the circumflex. And after that, the bed was prepared. We pre-dilated with a NC balloon and prepared the bed nicely. And then we planned a 2-stent strategy, decay crush. So the first stent was a 2.75 into 28 DAs in circumflex. We deployed that and then crushed the stent with a 3 into 10 NC. So we post-dilated the circumflex stent and did the first kissing balloon inflation with 2.75 NC in circumflex and 3.5 in LAD. Then we placed a 2.5 28 DAs in mid LAD and post-dilated with a 2.75 NC and a 3.5 33 DAs in LAD followed by post-dilatation. And we did the first spot with a 4.8 NC in the left main. Then after the post-dilating all the vessels, and we did the second kissing balloon inflation with 2.75 NC in circumflex and 3.5 in LAD and did a repot with a 4.8 NC balloon. So post-stent, we did an IVS. You can see the stent well expanded and the circumflex, the LAD ostium, the MSA was 6.18. Ideally, we would have liked a little bit bigger, but given the calcium and all, we could achieve around 6.18. But left main was very well expanded, and we got an MSA of 9.68, and all the stent was very nicely expanded and opposed to the wall. So this was the final result. And also, I would say that the distal circumflex, there was a small dissection, so I had to place a 2.518 stent. I didn't show for the want of time. I had to place one small stent there. So this is the final result. Nicely reconstructed left main bifurcation. And we took out the impella post-procedure on the table. And he was discharged in 2 days. Creatinine improved and also the LV post-follow-up has come to near normal. Now it's close to 2 years and he is doing very well. Take-home message, impella allows us to do a more complete revascularization and achieve good results. Patient tolerated the procedure well with no hemodynamic compromise when on impella. You should see, absolutely there was no fluctuations in the blood pressure when I was doing, but when we did the rotablation, slight drop was there. We had to use an noradrenaline for temporarily. After that, I switched it off. Meta-analysis had shown that mechanical circulatory support using impella for high-risk PCI is associated with better procedural and hemodynamic outcome. Further large randomized studies are needed to know the long-term clinical outcomes. Thank you for your kind attention.
So now we could discuss this case. That's congratulations. I think that was excellent demonstration of a very complex scenario. Yes, usually patients with closed bypass grafts have numerous comorbidities, not just the fact that they've got very calcific coronary artery disease, but they have numerous other comorbidities. And therefore, this is important to discuss. Any comments, questions? And while we coming to that, just 2 comments that I have for you. Yes. Of course, we, as you know, have developed our own score of India through a consensus at the CHIP CTO India, which is now published in Asia Intervention. It is different to the Western score and applies more to it. It was done through a whole days of discussion and consensus among 16 high-volume complex PCI operators of India, and Arun was one of them. And what we had achieved was that a slight difference. Our age goes to 75 for a score more than 2. Anemia gets excluded. With 2 other differences, we still have that if its score is less than 4, then we go for an intra-aortic balloon pump. 3 to 5, above 3 to 5, yeah,
5.
Is highly recommended. Of course, above 5, it's clearly. The second point I'd make is, if you're going for a support, it's going to be Impella CP. Now, of course, 2.5 won't be available, but we've always used Impella CP as the support of choice, because 2.5 is literally a very weak device.
This was done 2 years
Yeah,
back.
that's right, but it is a weak device, and of course I know that the finances are cheaper for 2.5, so that's another important aspect. And third important aspect is sometimes that when you do these things, of course, I'm sure, I think the emphasis, I forgot what the ejection fraction was in this patient.
35%.
35%. So very importantly, PA sats are another important aspect to be monitored all the time. And one of the criteria also for selection of mechanical circulatory support is a PA sats or a cardiac index.
Okay.
Ejection fraction less than 35 takes 1 point. Ejection fraction, yes, we differentiate it. That our ejection fraction less than 25% takes 2 points.
Okay.
Comments, questions, please. Sengu, you have anything? Deja? No, I don't see. Any comments? Sengu, yourself?
Arun has.
That was a fantastic case. Thanks for sharing that with us. I think it was very, very educational. I agree with all the points that Dr. Seth had said. So just two other questions. Given that you had put in a support device, how did you, okay, you obviously had to fix the left main, and I think it was a very well executed DK crush. So beyond where the touchdown was, I mean, even in your final angiogram, there was a little bit of a residual lesion. Did you, on imaging, what did that show? That's the first question. And number two, what was the plan? I think the graft to the PDA was also gone, and there was a collateral. Were you planning to do it at a later stage, or, I mean, you did a lot today, so what was the thought process there?
It was collateralized from the Lima. The PD was collateralized from the Lima. So I didn't do it. He's an 80-year-old person. I didn't want to do multiple procedures on him. And his ejection fraction is now near normal now, 55% now. 2 years follow-up, he's doing well. So I didn't do anything.
No, you had a great result, and you've got a 2-year result on a follow-up, so you did a great job. Yesterday we had a calcium session, and therefore we want to emphasize some of the points which we discussed at the calcium session yesterday. Remember the fact that we discussed imaging, and after rotational atherectomy in yesterday's case, we discussed assessment with imaging to see whether you'd actually got cracks, calcium thinning, and ability to dilate with a balloon to the fullest extent. Normally, we would expect, and I'm glad he stated that and pointed it out himself, that normally we would expect ostia of LAD to be much larger than this. And the left main criterias are now clearly above 10 and 10.5. So the original criteria, which you said were small vessels, etc., of 5, 6, 7, 8, which means 5 for the circumflex, 6 for the osteoproximal LAD, 7 for the polygon of confluence, and 8 came out of the Korean registry, not a randomized trial, a registry, looking at outcomes. But those data in the present era of Excel do not stand anymore and have to go to much larger the better. So we're talking about at least getting to an 8 in the osteoproximal LAD, and certainly 10 and 10.5 and beyond in the left main to get the best long-term outcomes equivalent to surgery. I'm not saying he didn't get what he wanted, and this is not a critique. This is just passing on more knowledge. He did a great job. That is not a critique of what he did.
Sir, I have one question.
Yeah.
The data which came from Park initially, that was the 5, 6, 7, 8.
Yes, correct.
But the Caucasians, they say 7, 8, 9, 10.
Yeah.
So what do we take? I mean, for the Asians...
yeah, I would take it larger.
Yeah.
I would definitely take it larger, because we want to do a job which is as good as surgeons.
Yeah.
Not in this case. This is a case which is no option for surgery.
Yeah.
But in general, if we do it, we're going to go higher and larger, and certainly never be satisfied with a less than 8 in the osteoproximal LAD, or certainly get far beyond 7 in osteoproximal LAD.
Yeah, I would have liked a little bit more. I got just 6.16.
Yeah, maybe if you'd done more plaque modification, say IVL at the osteas, or cutting balloon at the osteas prior to stent implantation, you could have got a bigger result.
there was a study published in Circ Cardiovascular Intervention in Feb 2024, recently, which was done in Asian population, where they showed a cutoff of 5.7 for circumflex, which is taken as 6.
6.
And 6 for circumflex, 8 for LAD, and 11.5 for left main, so about 12. So keep it at 6, 8, and 12. So that was a study which was published recently for Asian population.
Okay, that's good.
Yeah. Yeah. So that old thing doesn't stand anymore. Get bigger, the better. Okay? But good. Great job done.
Thank you, sir.
Thank you.
Thank you, Karthik.
Artie,
Let's-
you going to say something?
No, no, I think it's a perfect case. Congratulations, because you use everything in the right way, so congratulations.
Thank you. Please give a loud round of applause. So the next case is on my worst coronary nightmare. So I would invite Dr. Arun Kalyan Sundaram. Dr. Arun Kalyan Sundaram is the Asia Pacific CTO Club Director, India, founding course director of CHIP CTO. He is the Chief Division of Cardiology, ProMed Hospital, Chennai. And also, he is on the advisory board of various international bodies. So over to you, sir.
It's truly an honor and a privilege to be presenting today at PCR Live Interventions in front of such an august audience, so thank you very much. So I was supposed to talk about my worst coronary complication and how I bailed myself out, so here goes. 64-year-old male patient, multiple comorbidities, who's morbidly obese by Indian standards, and basically came in with pulmonary edema, and he had 3-vessel disease. Nothing really to write home about the usual risk factors, so I'll kind of skip this in the interest of time and that I have only 8 minutes. He did have an EF of like less than 25 on echo, so we did an MR to see which area we should go after. Turns out that everything was viable. The patient, of course, like a lot of our patients that we deal with in India, everyone knows somebody, right? So this patient's uncle was a retired cardiac surgeon in the US, and he kept pushing for us, like, let's have bypass surgery. The patient adamantly refused. In fact, 2 surgical opinions were sought just because I wanted to be sure that a heart team approach was taken. Cabbage deferred basically on account of both the surgeons turning him down and the patient saying no. So the plan was to do a, basically protected PCI. So here is the angiogram. Honestly, when I saw the angiogram, I was kind of thinking, oh my gosh, I really hope the LAD is not viable. I'll fix the right and get out. But turns out that that territory was viable too. So I'm just going to let this play for a minute. And you guys will see this in a lot more detail later, so I will keep going. Here's the right. Let everything play. You see some bridging collaterals, fairly short segment RCA. LAD seemed short too and had an unambiguous cap. The distal vessel wasn't really much to write home about. So now, I just, when I started the case, I just got some bilateral setup shots to just plan out everything. So there it was. So the first decision that was made was, okay, I'm not doing this without Impella. And this was a CP for those that are interested. This just shows it going in. I actually wanted to do this as a live case because I thought at that time I could save some money for the patient because I could get some free stuff. So that was the intent. So hence you see the recording and all this stuff initially. And the position of the Impella was good. I usually put in a pigtail, just confirmed that. It was also confirmed on echo. So life is good. So far, so good, right? And also, now comes the decision. Which one do you go after first? Again, potatoes. So I kind of said, all right, I'm going to go after the LAD for the following reasons. I thought I had an unambiguous cap. I thought it's a straighter segment, potentially an easier CTO. I didn't have bridging collaterals to deal with. And also, there were some collaterals that went from the LAD to the RCA. In general, I do not go after 2 CTOs in one sitting. However, in this particular patient, given that we are putting in an Impella, which is a pretty expensive device, etc., the plan was to go for complete revasc. And this was my strategy. I was going to go with a wide escalation, although it was a little bit more than 20, which is kind of an arbitrary number, but really didn't have great retrograde options for my LAD. So the plan was to go antegrade wire escalation. You guys can see the distal LAD. You do see a large diagonal there that fills too. So, am I seeing the time? Okay, good, I got 6 more minutes, all right. So antegrade wire did not work. So the next approach was, I said, all right, let me try parallel wire, because it still is a pretty straight segment, should be okay. Kind of a diseased distal LAD, so I didn't think it would be great for ADR, although that was kind of my backup option. So at this point, I have the wire, and I think you guys can kind of see that the distal wire is not, I wasn't too comfortable with the position, I wasn't sure. The key point is I had not actually advanced gear beyond, pretty much the proximal cap or a little bit into the CTO body itself, but still didn't work. And here's the money shot. Did not like this. I couldn't see anything, which is why I actually pulled back stuff and wanted to see what was going on. And as you can see from that picture there, the pressure was still holding up, and I'm like, wow, that seems like a large perf. And at this point, I'm just trying to see, okay, I'm going to see what's going on. Let me knuckle, figure out, sort this out. It was only at this point that I actually saw that there was a big perf. So that's that and 2 projections. The good news was, okay, there's a pinhole perf. I think I know where it's kind of taken off from, right? And so at this, all right, what do we do at this point? Okay, Impella is giving me some cushion. So it did proximal balloon occlusion. And now I'm kind of thinking, all right, I got to bail myself out. Am I going to coil this and kill the LAD? Can I potentially do fat embolization, inject thrombin, risk thrombosis in a lot of areas, call the surgeon? Of course, I did call the surgeon, who politely said can't do, just like I had told you a day ago. I also do a lot of these cases with another senior colleague, but unfortunately or fortunately, he had to kind of bail out that day because he had it actually was, I think, Tokyo valves or something, so he had to go. So here I am, kind of stuck, not sure what to do, and I'm like, so this is what I did, right? So of course, had to drain him. The effusion collected pretty fast, so that gave me some cushion. I was doing autotransfusion, and at this point, what I did was, I said, all right, let me go back. I did BASE, which is balloon-assisted subintimal entry. Unfortunately, I don't have the picture with the balloon and the microcatheter, but you guys can kind of see the microcatheter going into the subintimal space. Hulk is just because he knuckles, he punches. Okay. And now you kind of see that the LAD is dancing in the architecture of the vessel, but I'm in salvage mode now. I'm just trying to okay, I got to get this guy out of the table, out of the hospital alive, first out of the cath lab alive. So at this point, towards the end, you will see the knuckle go into the distal LAD. Not elegant, but got the job done. If I can skip to the end of this video, unfortunately, I don't have that control. So I'll just let it play because this is kind of important. Towards the very end of the loop, you'll see the wire just kind of break free. The knuckle, there you go, okay? So you're in the distal LAD. And now the distal part, of course, I didn't want to stent, prepare the bed, do DCB. And I still have to address the perforation, right? So something interesting that I want to point out is here, when I had ballooned it proximally, you notice that the perforation had significantly decreased. So this was kind of cool. So what I had done was gone subintimal, so the point of exit in the vessel was kind of covered by the flap. So what I decided to do at this point was just stented with a regular drug-eluting stent. And of course, you can always, there's some data to put in covered stents or papyrus within a DES, et cetera. But I thought, okay, let me start with a DES, a regular good old drug-eluting stent, seal it, see what happens, and then decide to put in a covered stent if need be. So this actually sorted the problem of the perforation. So again, for those, just to explain what I did, that's the perf. In B, you're kind of getting into the subintimal space, essentially using the subintimal flap to cover the perforation, and then using a regular drug-eluting stent to close it, okay? Now, I had lost the diagonal, and it was a suboptimal result in the LAD. And anyway, I was kind of thinking, okay, for this guy to have a meaningful thing, let me just fix the RCA. The other reason to fix the RCA was that if I stented the more proximal segment of the LAD, which I also needed to stent, I would be jailing the retroflex septal, which potentially gave me an option to fix the RCA. So the plan was, all right, we're going to just do this. So wire was across the septal, and I thought I'd use a retrograde wire as a marker for this was my plan. AWE, retrograde wire, reverse cart, and then we'll figure out if none of this works. So thankfully, so here again, at this point I wanted to fail and fail quick if something doesn't work. So antegrade wire failure, retrograde, wire escalation fail. You can kind of see it is. What's going on here? I know where I need to go, but wire didn't work. So I'm trying retrograde wire escalation, didn't work. So this was just reverse cart. I got 40 seconds, guys. I'm so sorry. I'm going to exceed time. But anyways, the point is guide extension reverse cart worked pretty well. So there's only one other teaching point in this case. There is no flow in the RCA. And this is something that I want people to know. Many times after reverse cart, when you don't have this, it's because you're dealing with I'll kind of go over the differential. But here, common things being common, the most likely culprit suspect is you have subintimal hematoma, which you can kind of see. So one of the solutions is don't stent more, just do a DCB, just do a cutting balloon, and I just followed it up with a drug-coated balloon. So I did all that good stuff. I kind of starred into the PL to just fenestrate the hematoma. And just DCB before the crux. And that was my final result, and I was pretty happy with the right. So, and then I stented the proximal LAD across that septum. Across the septal. I was done, okay? So after I left the Impella in, 48 hours later, here's the check angio, got this stuff out, left femoral closed with a perclose and an angioseal. And in terms of clinical follow-up, he did pretty well at 45 days. EF went up to 45%. And the key take-home is these, right? I think Impella actually helped me save this guy. It's not an advertisement for Impella, but I think it was a good decision to make. Given his overall hemodynamic status, Dr. Seth already talked about what are some of the criteria that you use for putting in an Impella, and this guy clearly met it. Perforations are bad. You need to know how to avoid it, but sometimes they happen, and when they happen, learn how to deal with it. So going to the right, that's the differential when you have no flow after a reverse cart. I just wanted to get done. I could have IVS'd it, but I knew it was a hematoma, so I just used cutting balloon. No CTO should be underestimated. I actually kind of thought, okay, I can do wire escalation, LAD, go real fast, do the RCA for my live case. But again, famous last words. Don't panic when you do have a complication. Work through problems one at a time. And even when you think you have it all planned out, plan more, go in with a plan. And if you want to learn more about complications, do come to Chennai. It's not too far from here. November 9th and 10th, Dr. Seth will be there. We are doing the Interventional Complications course with Chip CTO and Ifaki. Thank you very much.
Great, Arun. Great bailout, great case, very nicely done. So, Arun, see, you had the LAD perf, and the knuckle fortunately got into the distal LAD. What was your plan if you are not able to open it up? You would have your thought process at that time and what you would have done. If the wire didn't go, the knuckle went into the true lumen, right, after the perf. So what was your thought process when you were doing? What was your plan?
So here's the thing, right? So there are a couple of options. You have to seal the perf. That is of utmost importance. So once and base is a very controlled and a predictable way of getting into the subintimal space. So I was pretty sure I could get into that. All my other options that we went over, right? If you coil it, if you just inject thrombin, any other thing would have pretty much cost me to infarct the LAD. And once I was in the vessel architecture, at worst, I would have just gone all the way subintimal, right? Let's say if STAR hadn't worked, I could have still covered the proximal thing to seal up the perf. Now, usually STAR works. It depends on your experience level and how comfortable you are with knuckles. And in this case, in general, I don't like knuckling. There was a big diagonal, but I wasn't, like I said, it was either that or I'm going to lose this guy. So I did what I had to. But to answer your question, if this hadn't worked, I'd have just gone all the way subintimal, ballooned it, stented the proximal, lived to fight another day. As long as I have flow, I would have walked out.
That was tremendous. A
Thank you,
very
Dr.
complex case, and you really got out of the problem extremely well. I can imagine it would have taken a lot of adrenaline and expertise and thought process and finding solutions as you went along. And I think what certainly helped you is your expertise of CTOs to continue on in a scenario which was, for anyone, would have said, okay, whatever happened, let me just save this and walk off, even though the impella is there, and then come back, say, the next day and leave the impella in. But just secure the LAD, make sure that the perf is closed, and come back the next day for the rest. But you did everything on the same day, which was quite courageous. One of the things I would have thought through, firstly, of course, why not RCA first? Especially because the collaterals, septal collaterals came well before that total occlusion. And RCA seemed to be an easier CTO than the LAD. So that was the first thought which came to me. And therefore, getting one vessel secure helps you to be in control of a second vessel. But you, I think, thought that the LAD was easier than the RCA. So that, I think, was something that you got to comment on in hindsight. That's the first question. And the second is that I would have felt a perf where you're draining it continuously. My instant reaction would be put in a covered stent there, because a covered stent would have got there. You had the wire, you could actually get it there, balloon, and then work on the distal vasculature. So put in a covered stent like Papyrus and just work then on the distal vasculature and see whether you can get it back.
So again, fantastic points, and I think this really merits some discussion. So, you know, obviously, like I looked at the angiogram several times before I decided, okay, I think I can go after the LAD first. Both were, I mean, the right had the issue of bridging collaterals, the LAD did not. And generally, LAD tends to run straight. So, you know, I thought, okay, I should be able to do this. The other and the more important reason for that was the septal, which, you know, gives me a conduit for the right, actually takes off just before the LAD. And I thought if I fix the RCA, I have no retrograde option. So I kind of thought, okay, let me get this sorted first and then go after the right. You know, hindsight being 2020, like, I mean, yes, maybe the RCA would have been easier, but if I'd gone there and perf, then I would be kicking myself. So I don't know what the right answer is, but that was the, at least, method behind the madness. Was I thought this was going to be relatively straighter. I should use wire escalation as a strategy, which I couldn't do for my right, and also the fact that it gives you know, a collateral to the right. Now, going back to your second question, right? I had to have wire distal before I can think about covered stent. You need to secure the vessel, right? But at that point, I mean, I was in a much more controlled situation. Wasn't draining a whole lot. I had a guy just do this, infuse into the central line, and that's something that you guys should do. If you have a large perf, definitely put in a, you know, do some auto transfusion because it helps. So I was pretty much in control, and given that it's a smallish LAD, putting in a covered stent, high rate of ISR, the guy was not, he was 64, not 84, so I wanted to like avoid it if it were possible at all.
Any other points here? Someone's, I think there was
Martin,
going to
any
be...
questions on this?
Guys, any
Questions,
questions,
comments?
general questions
Yes.
about CTOs?
Yeah.
Or perforation?
Even last talk, no one from the back talked, so this is for you guys, not for us.
If we overlook the cost, we would have preferred to stage the procedure. Like would have done RCA one occasion, after 3 days you could have attended the other arteries. Because the chances of complications compounded the moment you attempted all the arteries in one go. Maybe the cost would have reduced, but the chances of complication and things certainly will add.
I couldn't agree more. In general, do not do this at home kind of deal most of the times. I mean, honestly, I do a lot of CTOs. In general, the principle always is do one at a time. Reason for this, however, that being said, when I do put in impeller or something like that. And for either case, like for either vessel here, going in without protection or without a support device is pushing your luck. So if you're going to do it, then you'll have to wait for the EF to improve, hopefully, and then you're going to go after the other one. And frankly, in this particular case, the decision was as follows. Not a great result in the LAD. Okay, I got the LAD, but I lost a diagonal. So fixing the LAD fully will also reduce my chances of fixing the RCA because of the collateral impingement. Hence, the decision to go ahead and finish everything in one go. Interestingly, other than the fact that it did take me about 6 hours to get this done, I had not crossed radiation limits. I had actually did not cross any safety limits in terms of, and the guy was intubated. So he was fine. It was just me. When he had the perf, I actually stepped out, I got coffee. I wanted to be sure I was okay, and then I proceeded. So there are certain stops that we use for CTOs. We didn't exceed any, so I felt comfortable doing it. However, completely agree, in general, do one CTO at a time. Thank you.
Thank you. Thank you. We can go on
Thanks,
to the
guys.
next one.
Yeah. So the next case would be presented by Dr. Vijay Kumar, and it would be on my structural complication. Yeah, so Dr. Vijay Kumar is Director, Interventional Cardiology, Fortis Escorts Heart Institute, Delhi. He is the Director, TAVI and Valve Intervention Program, Program Director for DNB Cardiology Teaching Program, and also he's been a co-investigator in various multi-center stent and drug registries. Over to you, sir.
Yeah, good morning, everybody. So I'm going to share two complications in structural intervention that we have experienced in the transcatheter aortic valve replacement cases, because that's the highest volume of structural interventions that we have done in the last few years. So coming to the first case, this is a 73 years aged person with severe aortic stenosis who was planned for TAVI, and his anatomy was a bicuspid aortic valve with the non-coronary cusp and the right coronary cusp fused. And it was a heavily calcified anatomy, whether the valves or the LV outflow tract or the leaflets, everywhere there was calcium. A large annulus was around 87 millimeters, and it was a horizontal aorta with dilated ascending aorta, usual component of these bicuspid aortic valves as a part of the aortopathy. So it was a challenging anatomy. Normally, such cases, if a young individual comes, surgery should be the first choice, but this patient had a severe LV dysfunction and a bad lungs, so he was planned for a TAVI. And so right from the beginning, the calcium was frightening, the anatomy was also scary, so we started facing problems while crossing the valves, number of attempts to cross the valve, and then the pigtail catheter would not go, so we had to take the smallest 4 French pigtail catheter. Then finally the balloon was, pre-dilatation was done with a great exhaustion. Then we had parked a stiffer wire, a more support wire, Lunderquist double curve for navigating the device, and a self-expanding valve was chosen, which was 34 millimeters valve. And this picture shows how difficult it was, an attempt to navigate, or the trajectory is going in the opposite direction and it is not going through the valve. So that's typical to the fusion of right coronary and the non-coronary cusps. So we were attempting, and then hoping that because it was not going, so we took more ways to sort it out. We took a buddy wire, buddy balloon, and we did a second pre-dilatation because it was a very small pinhole, tight aortic stenosis, calcified. We thought probably we have not made the bed proper, and that's why we did a second pre-dilatation with larger balloon and tried to navigate it, but it still would not go. And we attempted all these ways, and when we were shoving or when we were manipulating the device across the valve, probably there were 2 or 3 episodes of hypotension, and that hypotension was related to acute AI that was developing on account of the valve getting stretched. And finally, and suddenly the hypotension becomes intractable despite inotropes and all the hypotension was not recovering. So in the next few minutes, we had to take the patient on ECMO and the vitals were then maintained. And finally, we managed to shove the device across the valve and position it. So we positioned it in the cuspal overlap view and we then tried to deploy it. So the moment it was deployed, the next disaster happened that the valve pops out. Probably we positioned it, we saw it, but we were also, a lot of adrenaline rush was going on. ECMO insertion, the valve was not going, and then the cuspal overlap technique was seen, a lot of contrast was also gone. And we had checked in the LO cranial view also. The position was appropriate, but probably there was a calcium sump which pushed the valve up and the valve popped out. A disaster after all that long haul. Then we had to manage the embolized valve, took the goose snare and pulled it up. And then what next? So the next action that was taken was, took a balloon expanding valve which has a flex property, and that flexion characteristic to the delivery system facilitated easy navigation of the valve across the embolized valve. We positioned it rightly and then blew it up, and it needed some post dilatation because there was significant AI after dilatation of the balloon expanding valve. But then the balloon expanding valve, when post dilated a few 1 cc more, it reduced the paravalvular leak, and the paravalvular leak was minimum. Then at the end, the bobbing valve was also housed a little high in the distal part of the ascending aorta, and the balloon expanding valve was in the native aortic position, and the patient got stabilized. And at the end, it was a great relief that at least we could fix the balloon expanding valve. The hemodynamics were stable. The patient was on ECMO. He was weaned in 24 hours, but his LV also started improving, but we had to keep him for a few days on the intra-aortic balloon pump after weaning off the ECMO. And so this was a difficult anatomy right from the beginning. So at the end of this procedure, always you start thinking what could have avoided this. So after thought that whenever there is a difficult situation like this where the trajectory is not going to be right, you can go up front with a snare-assisted technique that has been conventionally practiced. But in the present times now we have the self-expanding valves also which have the delivery catheter systems having flexion property, and so that's not going to be the issue with the self-expanding valves also. And balloon expanding valves as such, they have a delivery system like Commander and all, which can be flexed properly through difficult anatomy, dilated aorta. So that is a fairly good choice of valve. Or the recent generation, the FX valve is also a self-expanding valve, but can be easily navigated through such anatomies. And the diagram just shows that how when the right coronary cusp and the non-coronary cusp are fused, and when you are crossing a valve, the trajectory, the force, and all the direction that you are giving, it doesn't direct the valve to cross the aortic valve. Instead, it goes in the wrong direction and the valve doesn't cross. So one has to be very careful when the non-coronary and the right coronary cusps are fused. So conclusion from this case says that always one should think all the difficulties that can be encountered in a challenging anatomy, and accordingly the plan should be done so that forethought spares afterthought and sorrow many times. And afterthought is always good, but forethought is better to avoid such situations. The second case is about a 76 years gentleman with severe aortic stenosis, and he was also a high-risk case for surgery, and we had planned TAVI. So it was a large anatomy. It was a bicuspid aortic valve, type 1. So the choice was between a 34 millimeter self-expanding valve versus a 29 millimeters valve. So 34 was coming to around 22 to 25%, and 29 was coming to around 7 to 9%, with a perimeter of 87.5 of the annulus and LVOT of 86. And we decided to go with a larger valve to give him a better hemodynamics, and we chose 34 millimeters. So this is the pre-TAVR hemodynamics, which shows a significant AS. Now we have done the pre-dilatation with a 22 into 40 millimeters, because if you go back, the 23.2 was the minor axis, and we pre-dilated with a 22 millimeters into 40 ZMED balloon. And we have taken a shoot which shows that it is adequately filling, and 22 was also filling, but we had already opened the 34 millimeters valve, and we went ahead with that. And this was positioning, and the valve, you can see in the second picture that it is getting on the point of deployment, and there is a small vertical infolded pattern which one can only see if the eye knows or if the mind knows that there can be a situation like this if you have chosen a large valve. And the valve does not open properly, and the patient gets incessant VT, VF, and patient has asystole. CPR was started, and we could understand that the valve has not opened and it is non-functional, and that's why the hemodynamics had completely gone for a toss. So we immediately, the actions that were taken to bail out this situation was, we took a 25 into 40 millimeter ZMED balloon, and we post-dilated this. So we could partially open the valve, but still you can see when the balloon gets deflated that the valve is infolded. The valve has become partially functional, and that's why the hemodynamics started improving and the blood pressure picked up. Still, and the gradient you can see on the picture is not there, but there was very severe, very high EDP, and there was a severe AI. So we took a larger balloon, and we did a second dilatation, post-dilatation with 26 into 40 millimeter, and hoped that it would expand, but there was still significant AI, and the valve constraint was still there across the chunk of calcium. And so the AI did not change. As you can see clearly, one portion near the non-coronary sinus, it is still enfolded, or it is still constrained. So what next was in the mind. So in such a situation, we took a second valve, and then the second valve was planned that we'll put a valve in valve and blow it, and then that would give a support to remove the constraint that we are seeing, or the enfolding of the first valve that we are seeing. But now the challenge was again to take this valve across the partially enfolded first valve. So we faced difficulty, but still we managed by using a buddy wire. We put a Lunderquist wire, and the valve could be negotiated through the first valve. And then the valve was deployed, and a post-dilatation was done to oppose the second valve across the first one also.
This was 29 or 34, the second one?
Same 29. Same.
This was a 34.
We took a 29 millimeter.
Okay, different.
Second valve was 29
Different.
millimeters.
Okay.
I'll just come to it. Both the frames expanded good, and residual PVL was mild, no gradients. The EDP came down to 20. So enfolding is a serious complication. It is better if it is detected. If you have seen when you are unsheathing, then the best strategy is to take the valve out and load a new valve and deploy it. That same valve can never be used if you have seen an enfolding. So you should, the first line of management is if you detect infolding, you should remove it. And that avoids the complication. But if it has happened after deployment, then the only steps that you can take are that we could do in this case.
Thank you, Vijay. I think there's a wonderful presentation with nice demonstration of how to manage these kind of complications. And particularly, you are in an experience center with high volume, you have different valve choices, and you have a team which is experienced, you can manage such complications. I think for beginners, it's very, very important to choose appropriate valve in the first setting. You know, in the first case, you see, they had used a self-expanding valve, and then they had to use a balloon expandable valve. This is a kind of luxury because not everyone can get two types of different valves of different companies because the cost is a major issue. And if you use the same company valve, there is most likely the second valve, one of the valves will be free. So it's very important, when you plan a complex case, it's very important to plan and decide what type of valve you're going to use. Look at the horizontal anatomy. What are the challenges you anticipate? You plan it and then try to solve the problem or plan it appropriately. And I think the first case was managed very well with a balloon expandable valve. And embolus, again, valve pop-out is again another problem. But why do you think it happened? Because in that case, I think the problem was you're not able to deliver. That was a reason, but you had to deploy the valve quickly. I know you went into ECMO and had to deploy the valve quickly. What do you think was the reason for the valve pop-out in the first case?
So the valve pop-out in the first case was that first of all, it was a very difficult navigation. So we were really, the patient was very sick and we somehow managed to cross the aortic valve and position it. So cuspal overlap view is the standard way in which these self-expanding valves have to be deployed. But always the practice is to go in the aleocranial view also, in the coplanar view also, and see if you are appropriately positioned or not. Probably there was a calcium chunk and it was a bicuspid valve, so we wanted near zero or a minimal deployment, minimal positioning. So the calcium was there and probably the valve got tilted the moment it was released. Although we released it very slowly, but probably there was some visual error or the calcium must have pushed it. It must have not got the right balance at a very shallow position.
Kind of trade-off when you use a self-expanding valve because you want to implant it as high as possible, shallow, with reduce the risk of conduction disturbance. But of course, you have to remember that the pop-out is a problem and you have to be extremely careful balancing both. And the second case, I think, again, was very interesting. And this is, again, a very important complication.
Vijay, you should go to that mic and give him the mic. Yeah.
Yeah, the second case was again a very, very interesting case because we often encounter a situation whether you choose a bigger valve or a smaller valve, and that situation, and we have to understand that if you use a larger valve, infolding is a possibility, but that's a preventable complication. I think we should keep carefully looking at the valve before you release the valve, and if you're able to identify that, then it's probably preventable. And I think Yadav was asking why a second valve, why not balloon expandable? Basically, this valve, you saw it was not expanding well at all, and in spite of using a bigger balloon, the infolding got better, but still the leak, aortic leak persisted. And that point, as you said, you have to increase the radial strength, and probably balloon expandable valve also could have worked, but a self-expanding valve is not a bad idea because here, again, the cost is a consideration here. You can't switch between companies. Again, the preferred first valve is the same valve, and if you don't have any other option, like in the first case, you can think of a balloon expandable valve.
So I'll just expand on that. You're right. A balloon expandable valve is a solution for that. You're right. The two things which happen at that time, you have to have the second person, which is the other company, in your lab. This is not off the shelf, so you actually have to have that. The second part of it is that if the second valve is the same valve and you implant it exactly at that point, it will actually open it up and it will do the job. And that the technician's already there with the valve, and therefore you have to prepare the valve rapidly in those circumstances rather than get another valve in. But you're right, that could actually be a solution. In fact, after this and after that first problem where we had to put a balloon expandable as a solution, the balloon expandable wasn't there. The guy had actually left. When we made the choices, he'd actually left. So he was 5 kilometers away out of the lab. because that patient, it was the first patient, yeah, he was on ECMO, we were able to wait for that 40 minutes for the balloon expandable valve to come and for us to put the balloon expandable valve. So we now have obviously both self-expandable and balloon expandable present all the time through a whole TAVI procedure till we have completed the TAVI procedure, so that we actually have the choices of both valves at any given time and to do whatever we want to do. And the fourth aspect is, by the way, the first patient did have a stroke. So when he woke up and he was off the ECMO and he was on a balloon pump, but he wasn't waking up, yes, he did have a stroke, but he recovered fairly rapidly and went home fully recovered. So the more manipulations you do inside the aorta, the more you're putting the risk to the patient, and therefore the choice could have started off with a balloon expandable valve in that patient. Clearly, easy to get across dilated aorta into an anatomy which is a very non-aligned anatomy. When you have a right coronary artery, non-coronary fusion, the whole orifice gets shifted towards the left side, which means towards the left coronary side, and then the anatomy becomes very tortuous and horizontal. It has to be pre-dilated well, and of course, the reason we took up a self-expandable was that was chunky, heavy calcium. There was outflow tract calcification, so we thought that we would put a self-expandable valve.
I have one question. In this patient, the first patient, you had a problem of hypotension and you had to go into ECMO. So the reason for hypotension was, you mentioned it, that it was because you caused a
when we were pushing the valve, it was
the valve. No, I was just wondering whether, I know it is a difficult situation, but not all of them have the ECMO, not all of them can also afford an ECMO. So do you think that you could have still taken a quickly, if you had a balloon expandable immediately, you could have done it, or because it was not like a perforation, or it was not a major problem. It was only AR which could have been transient also.
With so much of manipulation, the first cause of hypotension one would fear is perforation or injury. So that injury was ruled out by the echo, and which reflected that there was no trauma and there was no pericardial collection that was the cause of hypotension. So the only thing, and it was happening, the hypotension was happening whenever we were pushing the device across the valve. And that's the only, we did not see AI because the BP was also so low. So on the transthoracic echo, we could not figure out a color Doppler showing AI, but that's the probably mechanism which led to the AI.
I personally think it was multifactorial, because if it's AI, then you just bring it back and then wait, and then you can do many things. I think it was our excessive pushing also on the aorta. I think it was the valve itself, and I think he stroked out. He stroked out at that time. He stroked an vasovagal, and that crashed him completely. Because obviously he did have a stroke, so that must have happened at that very time. So it was a combination of issues which crashed his pressures, and it actually sank. And obviously, we are very good at ECMO because we can put people on ECMO within 5 minutes. We're a team which put people on ECMO, resuscitation program within cath lab, because we're all self-sufficient in ECMO ourselves, is so fast that for any crash, we actually say, ECMO, why waste time around? And then do the job.
And
Yes, we have. And with the cheaper circuit, yes, that's easily possible to keep that circuit.
And
so we have primed.
And one important message also about popping up, I would say, especially for the beginners, experienced people can do it better. But if you are if you have a bicuspid valve and you want a shallow deployment, you should definitely go by the cuspal overlap view, which helps in positioning it more shallow, but always a coplanar view. And you could go a bit deeper instead of going very perfectionist like a zero deployment, because in a calcified anatomy, bicuspid, if you are putting near zero, then you are likely to pop it out.
Just one question. In the first case when you showed, right, when you had to pull the valve back, are there tips and tricks? Do you always use a gooseneck snare? Do you use one? Do you want to just talk about that a little bit? When you remember the valve you had to pull it back in the first case. What are some tips and tricks? How do you usually go about it if that happens?
How to manage an embolized valve?
How to manage an embolized valve? How do you do it? What snare? Any advice?
So most important is if you are running a TAVI program, you should always start your case by checking your TAVI bailout kit, that you have all the hardwares or not. So snare is one of the most important hardware that comes into use when a pop-up happens. So generally large snares are used, and you have to go from the other side, from the left femoral side, or from the radial also you can take these snares and then catch the hooks of this and keep it pulled. You have to deploy it, or you have to park it in the ascending aorta somewhere, or if it easily comes down towards the descending aorta, then you can put it in the descending. But generally a self-expanding valve which is fully expanded, and if the aorta is not very forgiving, then you will get stuck somewhere near the subclavians. So it is better at the distal part of the ascending aorta itself, generally it is parked.
Yeah, and you need to catch two of them to actually bring you put two snares to really pull it really down into the descending aorta.
And sometimes, the
into
radial
the
and
thoracic
femoral may be
aorta,
different,
but you can actually tear the aorta as well. So the main thing is never put it across the innominate and subclavians.
Because
I think we will move on because in the interest of time we should end, but we've had tremendous cases and a real lot of learning from these cases. Complex PCI in an elderly patient with a very hostile coronary artery disease, left main, circumflex, heavily calcified, low EF, extremely nicely done, good planning, good execution, great final result, and of course, a 2-year follow-up. So I think Dr. Karthik, great messaging, well done, and this is the sort of stuff that we need to clearly teach, train a lot more young interventional cardiologists, because complex high-risk PCI needs to become an integral part of training, not of execution, an integral part of training at most experienced centers in a very systematic manner for our young gen interventional cardiologists. The second aspect, of course, was my worst nightmare from no other than Dr. Arun Kalyana Sundaram, a master of CTO, and clearly demonstrated a very high-risk case of an ejection fraction of 20%, who he salvaged masterfully. I know that I'm better than him. I wouldn't have caused the perforation. But if he did cause the perforation, he is masterly at salvaging not just the perforation, but treating the whole case. But he did that systematically. He didn't do like a cowboy. He thought through every step, and he decided that he was going to proceed on to give complete revascularization, even in situations where others may not have or perhaps should not have. But that's because he has the skills and the experience of a CTO operator to be able to plan 3 or 5 steps ahead and therefore be able to execute it. Even to the last point, I thought was brilliant, that understanding a hematoma, which we occasionally have, and we don't understand it, and we don't solve it, and we say, but we ended up with a poor flow. But that's because it's a hematoma, and a hematoma has to be treated with a cutting balloon, and not just keep on stenting till you see the artery disappear into nothingness, and then say, oh, what's happened? And he showed the brilliant end result of a flow which was restored in the vessel, and he fixed that with drug-coated balloons. So I think that last messaging also was equally important, because that could happen to any of us. We create hematomas. We see all this happening even during routine stenting and don't recognize it and keep on stenting all the way down. So that was good. And finally, of course, Vijay, well done in showing two really complex scenarios and saves of 2 important complications which could happen to any of us. And perhaps there were 2 aspects to it. One, Could the choice of valve have been different? And by the way, there are no master operators throughout the world who can actually define accurately the choice of valve in bicuspid anatomy. There are none. Despite the number of indexes of sizing that we've created, there is still no master who can actually define what is the size we need of bicuspid valve. The choice of valve. And finally, but what has to be well understood is, complications will happen to all of us, irrespective of our experiences. But knowing and having systems in place to preempt and to be able to handle them, our toolkit, our mechanical circulatory support, the expertise of keeping patient alive, and therefore handling complications becomes an integral part of a successful training program. And that's what we got to understand and do, not just for our coronary cases, not just for all we've learned, for structural as well as coronary cases. That's the message. Thank you.
Thank you so much.
Anything else, because we're ending this session? Reja, why don't you, this batch ends its session, I think.
So
Yes,
before-
you want to give
So
mementos?
before we move on to the next session, we would have a small felicitation. So I would invite Mr. Rohit Nayyar to please felicitate our
Yes.
Indian faculty.
It's a late-breaking trials.
So starting with Dr. A. Srinivas Kumar.
So it's your late-breaking trials, isn't it?
Then I would invite Dr. Karthik Vasudevan. Next, Dr. Arun Kalyan Sundaram. And Dr. Vijay Kumar, please.